Good afternoon, everyone. Thank you all for joining today's Journal Club. We welcome you all to the statewide Journal Club presentation for this month. And I would like to thank the IPS Tamil Nadu chapter office bearers, Dr. Sadanand sir, Dr. Babu Balasingh sir, Dr. Arun Kumar sir, Dr. Satyamurthy sir, Dr. Arul Saravanan sir, and Dr. P.P. Kannan sir. And also, I would like to thank the RCBC committee members, Dr. Shivanand sir, Dr. Maikandan sir, Dr. Vanishri ma'am, Dr. Veerat sir, Dr. Arumuganathan, and Dr. Shivaraman. And it's my pleasure to introduce Dr. Arumuganathan sir, who is an experienced psychiatrist and medical educator with special interests in mental health advocacy, suicide prevention, and gender-inclusive healthcare. Dr. Arumuganathan sir is the associate professor and head in charge of the prestigious All India Institute of Medical Sciences, Madurai, and sir has completed his MD Psychiatry from AIIMS, New Delhi. Dr. Arumuganathan has led and guided multiple ICMR-supported research projects, and he has 14 publications to his credit. Dr. Arumuganathan will be presenting today's paper on Adjunctive Antipsychotics in Major Depressive Disorder, a systematic review and network meta-analysis by Roger McIntyre et al. We look forward to an engaging discussion, sir. Over to you, sir.
Thank you, ma'am. Thank you for the warm introduction. At the outset, I would like to thank the TNIPS office bearers and the RCBC committee members and my colleagues for giving me the opportunity to present. So without taking much time, I think we'll move on to the presentation. Dear participants, so the topic for the discussion today, the article I've selected is from JAMA Psychiatry, published on May 6, 2026. The article is Adjunctive Antipsychotics in Major Depressive Disorders, a systematic review and network meta-analysis, as said by Roger McIntyre, RS et al. Right. Myself, Dr. Arumuganathan from AIIMS, Madurai. Yeah. So the Journal Club presentation will be on the following outlines. First, we'll discuss the background and the clinical context as established in the article, followed by the methodology and the study design adopted by in the article and the authors, the key results, the figures, the discussions, and the limitations, as well as the role of industry funding and conflict of interest analysis. So from this will be the critical analysis part. We'll also look into the bias assessment done by the author as well as myself, and the translational potentials, that is for the clinical practice and its limitations. We'll also look into few external critics and commentary on the articles, as well as few take-home messages. And if time permits, we have certain questions for the audience, if possible. If the audience could put in more questions, it is well informative and educative for that purpose will be solved. So moving into the presentation straight. So the background and the clinical context, as we know, depression is going to be the leading factor that causes disability-adjusted life years in the years to come. And as per trials, 30% of the population diagnosed with depression, they respond to first antidepressant. And about 50 to 60% of them do not respond or fail to respond to antidepressant trial even after 1 or 2 drugs being tried on them. And as such, FDA now has approved around 5 drugs as adjunctive atypical antipsychotics for the treatment of major depressive disorders. There are a few other drugs that has been approved for bipolar depression, but this is the drugs list that has been approved for adjunctive treatment in major depressive disorders. Not the standalone treatment or monotherapy, it is adjunctive treatment. Yes. Why this paper matter is, as of now, we do not have any direct head-to-head randomized control trials in the 5 FDA-approved adjunctive antipsychotics for depression. The clinicians lack data to guide them in the drug selection and sequencing so that they could provide better services to the patients. And there has been significant differences in the way people tolerate the drugs. That is their weight gain potential, EPS potential, that might lead to discontinuation of these drugs. So the drugs that has been discussed in this articles are the following: aripiprazole, brexpiprazole, cariprazine, lumateperone, and quetiapine XR. Yes. So moving into the methodology and study designs, the authors discuss the data sources. Like after Prospero registration of the trial, they looked into the data sources, primarily PubMed, Medline, PsycInfo, Cochrane, Embase. They also did some manual search, and I need you to look into the date that has been mentioned from inception to July 15th, 2025. So that is the cutoff that is being described by the authors. That is FDA approved drugs that has been that has undergone RCTs till July 15th, 2025. So the inclusion criteria include pivotal double-blind RCTs, any drug that has had 2 or more RCTs, adults population, so they do not cater to the pediatric or adolescent, child and adolescent population. So anyone above 18 years in the part study, and DSM-4 or 5 criteria that is being used in the diagnosis of major depressive disorders, and inadequate antidepressant trial response. That is, the definition is not pretty clear even with the FDA. There is an overlap of this diagnosis between antidepressant response inadequacy as well as treatment resistant depression. Yet they've choose the inadequate response category. That is something that has not reached up to the level of a 50% improvement in the scores. And the drugs should have been FDA approved for adjunctive antipsychotics. So who have they excluded? Any trial that has included monotherapy of drugs, especially and unapproved, like risperidone has been used and olanzapine fluoxetine monotherapy has been tried. So these studies were not included in the meta-analysis, and any studies that involve pediatric or child and adolescent population has been not included. So what are the primary outcomes they have considered in the study? First is efficacy. That is more than or equal to 50% reduction in the Montgomery Aspects depression rating scale scores. Second is acceptability. How much have the discontinuation rate be due to all causes? So that has been taken as acceptability. And the endpoint, the time duration they have kept is a minimum, is about 6 weeks, is considered as the adequate trial period as the endpoint. So the secondary outcomes they have looked into and the exploratory outcomes they have looked into are remission. So in primary outcome, it is the symptom response about 50%. Here it is remission. When the MADRS scores goes less than 8 or 10, or change in the severity of the symptoms, or discontinuation due to adverse effects due to drugs or adverse events. And the exploratory outcomes include a clinical global impression severity scale, clinical global impression improvement scale, Sheehan's disability scale, more than or equal to 7% weight gain, and extrapyramidal side effect or akathisia as the reasons for discontinuation. So the first of improvement, severity, disability, as well as adverse events has been looked into as the secondary outcomes here. So the statistics they have used are the Bayesian network meta-analysis, which is basically when you have some beliefs based on your historical data that is being available, and you want it to be compared to the current trend. So there are 3 points. There is your prior belief, there is a current level of evidence, and what do you infer from that level of evidence to the future truth. So based on this historical interpretation is considered, or the probability of a historical interpretation, how much would be that data is the Bayesian approach, followed by the frequentist approach, which is basically focused on the raw data that is available at hand. And the data in Bayesian approach is expressed as credibility intervals, and in frequentist approach, it is used as confidence intervals, 95% credibility limit and 95% confidence limit. So they used random effects model so that, over the years, the data period is too long. So they considered that at all studies might not be having the same exact methodology or the outcomes, but all studies focused on improvement. So where do we fix these? So what is the effect of different factors or different truths that is being taken into account for modeling? So they use the random effects model. And this MCMC 330,000 iterations, it basically means like if you're on a valley, on a trekking valley or something like that, you see a range of mountains and you have to decide which all mountains takes the most significant point of time. So this MCMC 30 iteration is used for counting on the Bayesian approach policy. Like you send out 5 people to explore the mountain ranges, ask them to pick out the peaks from that, and you set them like to be more probabilistic in nature. You set them to choose every 5th step or the 10th peak in the mountain range to be included in their heights. So like that, if they move around, like 4 people moving around 30 times from one location, it gives around somewhere around 120,000 points to be noted. So with that, when they plot the graph, it doesn't appear like some drift or a logarithmic line. Rather, it appears exactly like another normal distribution curve. So it gives you a historical interpretation in a Gaussian form. And then last of that they have used is the node splitting for consistency of the findings. Node splitting is basically used when we have a direct comparison between drugs and there is an indirect comparison through placebo. So that is where node splitting works better. So the selection, how did they go on to select these studies? So when they looked into the literature using the databases using the mesh terms, they found that 1,407 databases, they identified 1,407 articles, and out of those, 65 fulfilled the eligibility. They had full text for eligibilities, and of that 45 has been excluded when they don't fit into the exact criteria that has been chosen by the author. And finally, they also did some manual searches or looked into Google Scholars and other registries to look for trials that is looking after all these antipsychotics as adjuvants in antidepressant, and they found 6 more articles, out of which when they use these exclusion criteria, they found this 2 articles to be included. So the final number came to around 22 RCTs were included in this network meta-analysis. So these 22 RCTs, they had a total sample of 10,962 and the placebo population accounted for 4,596. So this is the number of trials for each drugs. Aripiprazole had the maximum number, which is 7, followed by brexpiprazole, which is 6, cariprazine 5, lumateperone 2, and quetiapine 2. Lumateperone, one particular thing is lumateperone, basically the RCTs were not published at the time of inclusion in the during the time of the systematic review. And the number of participants is highest for aripiprazole 1297 and lesser for lumateperone, which is 483. And the maximum duration, average duration has been around 6 to 8 weeks, and the maximum duration has lasted for 24 weeks. Except lumateperone and quetiapine, all other drugs in the RCT has been either used as a fixed or a flexible dose regimes. And one thing I want the audience to note is that out of the 22 RCTs, 21 were industry sponsored or backed by the pharma companies. which produce the drugs, and Lindsay et al.'s 2015 articles on depression adjunctive treatment for the elderly geriatric population. This was not included in the primary analysis, but they included in the sensitivity analysis, saying that this particular article alone had a mean age above 60, and that is the reason it might lead to heterogeneity of the population, and they have included them only in the sensitivity analysis. And this is sponsored by NIH. So network plot for primary outcomes, efficacy, and acceptability. So this is the network plot. Initially, the first photo depicts across individual drugs. If you find that it is as such mentioned in the table before, there is only one cross analysis comparison between brexpiprazole and quetiapine. Rest of this are a placebo to the drug, that is placebo controlled trial alone is there. So what do we understand from this? Rather, usually in a network analysis, you find the figures to be more of a loop kind of one drug interacting with the other, or a drugs head-to-head trial between drugs is also being part of the network meta-analysis. But here, the topography of the network meta-analysis app is like a starburst. That is only placebo to the drug is the major thing. And here it is with the, on the B, it is primarily stratified for the doses. And you find the thickness of the line or the weight of the line is basically the number of trials, and the placebo and the dots are corresponds to the number of participants in each trials. So what is the results they found using this? So two primary outcomes, one is efficacy and the other is acceptability. So efficacy scores more than or equal to 50% reduction, and acceptability is all cause discontinuation as the primary. So what do you find? We find lumateperone had the highest relative risk of 1.72, highest effect is being seen, and the surface area under the cumulative rankings, lumateperone had a 0.95 and aripiprazole had 0.79. They found this to be more or less overlapping in nature. Rather than saying it as a distinctly higher thing, the credibility interval limits, they actually overlap between them. So though effect-wise, the mathematical expression-wise, lumateperone appears as the highest effect drug. On the other hand, a lower dropout ratio is equal to a better acceptability of the drug, and hence a relative risk more than one is, or more dropout than placebo, it is considered as a worse acceptability. So here aripiprazole had a better acceptability with a and here one point I want to note is the cariprazine part, which has a narrow interval here in the credibility limit. So the paradox here is lumateperone claimed by the authors has the highest efficacy but has worst acceptability. So the worst is about 2 to 3 times the original drugs. So the secondary outcomes also almost depicted the same. The remission in MADRS scores were highest for remission seen is maximum in lumateperone here, and the least is seen with cariprazine. And the other is the severity score. Again, severity change is observed maximum with the lumateperone, and it is also seen the least with quetiapine here. The third is discontinuation due to all-cause adverse effects. When compared to placebo, lumateperone had the maximum. And weight gain, surprisingly, we find aripiprazole is one drug that had highest risk for weight gain, even more than quetiapine as per this analysis. And lumateperone, the weight gain remained non-significant, not much. This is one drug which had the least weight gain as per the analysis when they explored into the findings. Yes, you can find the plots in the article as such, giving you a varied movement from the median point. So what do the authors discuss when interpreting the findings? The author says efficacy hierarchy is established. Almost all of the antipsychotics that has been included here, they produced a reduction, a change of more than 2 points in the MADRS scores than the placebo. So there is a clear efficacy hierarchy being emerged. And lumateperone followed by aripiprazole, brexpiprazole, cariprazine, and least with quetiapine. So that is the hierarchy here. However, the interagent difference that do not exactly reflect the pharmacological differences is the thing that the author's conscience. So he also thinks that this could be probably an artifact due to sample heterogeneity between the trials. Could be due to different places, different population, different study designs, in the sense like the enrichment designs and all could have accounted for this change in efficacy. On the other hand, the acceptability hierarchy, there is a clear gradient observed with drugs that had dopamine partial agonist activity as aripiprazole, cariprazine, and brexpiprazole had a better acceptability than quetiapine, and lumateperone had the lowest. So results from adverse effect related discontinuation, they accorded primarily for the acceptability outcome. And this is almost consistent for the doses too, as they did in their analysis. Regarding the exploratory outcomes, secondary, so remission and the improvements in CGIs and SDS, they have also supported the primary findings, except for lumateperone, a drug which caused lower weight gain, but still remained not much acceptable because of the somnolence effect, probably. And this says tolerability and metabolic safety are distinct constructs and they don't go hand in hand. Dosing design also has a significant impact on acceptability. This lumateperone is used only as a fixed dose, 42 milligram without any titration. So this initial higher dose, which they say could have resulted in the drug exhibiting more adverse effect and leading to higher discontinuation rate. And the third is the placebo response confirms the hierarchy. Like if you find in the article, you find the placebo also had better responses. They say aripiprazole, as the era progresses, aripiprazole, brexpiprazole comparisons had a lower placebo response, and cariprazine and lumateperone had a higher placebo response. So that in fact could have affected the hierarchy in which this particular drugs has been arranged as the outcome. So the limitations as acknowledged by the authors include the following 8. One is, they say there is no direct head-to-head trials that has been included here. So we cannot confirm the superiority of one over the
other. Everybody will be sleeping. I'll do.
Second, heterogeneous placebo response. That is a 2 times difference in placebo scores, like almost from 5 to 6 in aripiprazole group to 12 in cariprazine groups. This might have resulted in artifacts of the trial design and might not have been the direct effect of the drug as such. Predominantly industry sponsored, 21 out of 22 trials, except the one that is included only in the sensitivity analysis. It requires a word of caution, as they say. And heterogeneous inadequate response. The studies included in the trial did not have a homogeneous definition for inadequate response. Few drugs like aripiprazole and brexpiprazole they included prospective antidepressant failures also, while cariprazine and lumateperone included historical failures. And to an extent, cariprazine had, one trial had said that at least 3 drugs should have been failed. So that is the difference in the selection of the participants here. There is a heterogeneity in the definition of inadequate response. And then short-term evidence. Almost all of these drugs trials had lasted a maximum for around 24 weeks, but a median of around 8.5 weeks. So there is a knowledge gap, and that is the reason you find only quetiapine is the only drug that has been approved by European medical agencies for adjunctive treatment of depression, using antipsychotics in depression. The other drugs have not yet found its place in the EMAs, and that leads to a knowledge gap there. And there is no subgroup analysis, like based on what kind of symptom improvement is seen in with what type of drugs, what symptoms improve faster or better. That kind of a subgroup analysis on the phenomenology is not been done, and they're not addressed for most real world conditions, like where it is more often co-occurs as a mixed features or an anxious or some substance use or cognitive dysfunctions have not been addressed here. And the pediatric populations were excluded. So generalization to pediatrics or child and adolescent population cannot be done because there is an increase in the frequency of diagnosis of depression in this population in recent years. And no cost effectiveness analysis is being done, because when a drug like a lumateperone, which is a bit costlier and a newer agent, if it is planned to be introduced, then it needs a pharmacoeconomic consideration also. Yeah. So what do they conclude? Efficacy and acceptability. Yes, there is a difference between adjunctive antipsychotics in the treatment. However, clinical decisions should be weighed between the estimated efficacies as well as acceptabilities. We need to weigh both and come to a conclusion. So efficacy, no single agent dominates. Lumateperone in efficacy, but last in acceptability. Aripiprazole, on the other hand, offers a better or a best combined profile. Efficacy also second and acceptability also first. So one size fitting to all patients is not here. And jurisdiction, where does this drug work? Right? FDA approval is sought in the US, and EMA doesn't permit that because there is no long-term data available here. There is a critical knowledge gap. There is no maintenance evidence. So getting approval in EMA would further be difficult in this population because it requires long-term data. So what do the authors suggest? They suggest go for a head-to-head trials between drugs. Look for strategies for switching with bupropion or other drugs. Compare it with treatment-resistant depression drugs like esketamine, or do a trial on predictors and moderators of response by phenotype. What type of symptoms has better response for what group of drugs, and long-term maintenance efficacy, since only acute efficacy is known till date. So finally, these addresses the knowledge gap that is there and supports decisions to practitioners and persons to take a informed decision on drug approaches and algorithms and reimbursement considerations. So these were explained by the authors. What do we find when reading the articles? 95% of the trials included in the analysis is industry sponsored. Is a big ask here. But how do we go about this? all drugs comes to market based on industry's efforts. So how do we weigh the evidences and the industry's influence on the outcome? So almost all of these trials being sponsored. Aripiprazole alone, one trial is from NMH sponsored, that is independent. Looking into the author's conflict of interest declaration, all authors have received fees from one or the other pharmaceutical companies that has been involved in this drug trials. And surprisingly, intracellular therapies is being acquired by Johnson & Johnson in 2025, and lumateperone launched as adjunctive MDD therapy. It is approved in November 2025. So if you look at the inclusion criteria or the search, it is from inception to July 2025. But how did a drug like lumateperone, the inclusion criteria says FDA approved drug, comes into the analysis all of a sudden, which gets approval only after the study has been conducted, that meta-analysis has been conducted. So this, and how did the authors get this drug data? First, one of the main author is a co-author in another RCT by on lumateperone, and the other article has been provided by the company Intracellular Therapies to the investigator or the authors for inclusion in the network meta-analysis. So both studies has been not received through databases but through direct access to the unpublished data. And simultaneously, Johnson & Johnson has issued a press release 2 days prior to the publishing of this article, promoting the same drug using the same network meta-analysis. So this somewhere blurs our line between whether this is some kind of a marketing for the lumateperone that is going on, or is it the actual response that is being seen. So as said, all authors somewhere or other is involved in with the funding agency or the pharmaceutical agencies here. So looking into the bias, first is the placebo response bias. So as mentioned earlier, aripiprazole group and brexpiprazole group had a lower placebo response, and cariprazine and lumateperone group had a higher placebo response. So how does this placebo response impact our study outcome? Basically, if we consider aripiprazole era, the placebo response is more often less because there is some hierarchy of placebo response across eras. This is basically improvement in the strategies of how placebos is being given, as well as the amount of care that is being given with more ethical handling during trials, or more support to our participants during the trial. The placebo response for antidepressants has been increasing across the years. So here, how does this matter? If you find in one of the trials, cariprazine has a relative or a reduction, absolute reduction in score of around 14.1, and lumateperone has an absolute reduction in score of 14.7. But the advantage of lumateperone here is they used a design to enrich their study so that the placebo response doesn't affect them much, thereby increasing their efficacy. However, cariprazine, that advantage is lost, and that makes it the last in the count. So it impacts them significantly. Then regarding the network geometry bias, that is the star topology, the picture which I showed first, that is everything connects only to the placebo. There is no loop being formed in between. So there is no head-to-head trials that is happening. And the nodal analysis which is done is basically done when there is a head-to-head and there is a drug to placebo method. The direct and indirect both are available. It works better. It says which is significant or insignificant. Here, one side of the loop is significant and the other side does not exist at all. So they say nothing is there to dispute this claim. So the verifying of transitivity is not possible here since there is no closed loop available. Sample size imbalances. While aripiprazole had 7 trials and a population of around 1297, lumateperone has only 2 trials and 483 patients. So fewer trials is susceptible to overestimation of the effect, and a wide credibility interval is reflecting the same uncertainty. Dosing design heterogeneity is another problem here. They use both flexible and fixed doses. So whenever a fixed dose regime is used, usually the finding shows more efficacy as seen in drug trials. And publication or reporting bias. The negative trials reported are missing in this RCTs, and as said, 2 trials on lumateperone, both unpublished. The question arises, is it a synthesis of evidence or is it a real evidence? Is a question here. And the last is clinical heterogeneity. Based on the inadequacy definition, cariprazine and lumateperone included trials, participants who had historical failure of drugs on antidepressant therapy, while aripiprazole and brexpiprazole, they had included prospective antidepressant failures. So historical failures usually has a lower bar, but between cariprazine and lumateperone, the failure on 3 drugs and 2 drugs is being considered. So duration of index episode, prior treatments, baseline levels all varied between the participants in different trials. So that is with respect to the bias. And then moving into how does this findings translate into our day-to-day practice. So the translation potentials and the limitations that we don't see here. So this is the first network meta-analysis that compares the 5 adjunctive antipsychotics that is approved. This helps. There is a comparison on the dosings of individual drugs also. So that helps in precision of dosing. It keeps into account what a doctor wants from the patient and what the patient expects from the drug. So they do acceptability and efficacy, both has been considered. So that helps in a shared decision-making principles. For sensitivity analysis, they have included the Bayesian as well as frequentist approach. Post 2010, this cutoff is primarily used to look for more placebo controls, better placebo controlled trials, and including older adults only in the sensitivity analysis to maintain homogeneity. Enhances the robustness. The study in their supplement gives it is Prisma compliant and Prospero registration has been done with pre-specified outcomes. But the date for conducting this end date, that has been missed somewhere. So the authors had acknowledged no head-to-head trials, short-term trials, only no pediatric generalization, and did not examine the baseline moderators that is commonly co-occurring and cost effectiveness. But what they missed is the real world effectiveness. In real world, we tend to find that patients come with psychosis and with comorbid medical illnesses and other comorbid psychiatric illnesses too. And they cannot be a highly selected population. So the number needed to treat in real world will be much higher than RCT estimates. Lumateperone is a drug that produces significant somnolence. So that particular part has not been discussed because people expect to function next day and be active next day. So that could have impacted or caused a significant dropouts in their condition. Long-term metabolic risk could not be assessed, and long-term EPS potentials, tardive dyskinesia risk, and weight gain or insulin resistance could not be captured. Equity and access. Lumateperone is a brand new drug. So for us to change to a higher cost drug than a generic drug, how strong the evidence could be is not being exactly said. And concurrent use of psychotherapy addressing comorbid anxiety and substance use disorders. These are major determinants for real world improvement, not a remission of symptoms. Not a response to drug, but remission of symptoms is also based on these functioning, and these are not included in the analysis. So what do the other people have to comment on this article? So Leslie Sitrom says, since there is no head-to-head trial, it is okay to have this kind of a network meta-analysis, which is valuable, but the interpretation requires additional context. So it could not be blindly interpreted as one drug is superior to the other, because there is no head-to-head trial here, as well as the acceptability paradox, which needs more exploration. He in HCP Live says he's the one who brings out this marketing trends in Johnson & Johnson and the publication sequence of lumateperone as a trial here. So that critical aspect of market-driven outcomes is being discussed by same Leslie Sitrom in HCP Live. Historically, Spillman's in PLOS medicine, they say like whenever we try to find adjunctive antipsychotics, it produces efficacy which is small to moderate, but it has little evidence for improving the quality of life, but with the risk of increased adverse effect burden. So industrial sponsored studies more often produce larger effect size than the independent ones. So with this lens, if based on Spillman's lens, if you look at this article matches that particular aspect. The general methodological concern has been set based on the star topology. So the other part of the loop does not exist. There is no closing of the loop. Hence, all non-insignificant finding in node splitting analysis is not informative. So this fundamental limitation has not been clearly explained to the readers here. In the article, in the journal itself, in JAMA Psychiatry itself, we find till a week back, there were 3 commentary on the articles. The first is by Fisher. He comments on the response rate as primary outcome and absence of blinding integrity. What he says is the persons are already partial responders. So keeping response as the primary outcomes might not serve much effect. Instead, we need to keep something remission, like a remission, which is a continuous effect. So need not dichotomize as more than 50 or less, focus on the response aspect more. So that is his primary recommendation. On the other hand, almost all studies included in this RCT had a problem of blinding integrity. So every drug had different sets of side effects, and that side effects for a rater who's backed or who's been paid by the industry to rate the symptoms, they are not completely blinded. Once they know the side effect, the rating goes obviously higher. So rater expectancy bias is being there. So quetiapine causing sedation, aripiprazole causing activation, and lumateperone causing somnolence. All are perceptible and rater expectancy bias inflates the effect size. This is a significantly valid critique on the article. So yeah, that's been explained. And the second is by Furukawa. He focuses, he doesn't counteract much on the article's findings, but instead he focuses on how the article depicts its finding. So he says the arrangement in which the plotting has been done is very not very appealing for a reader. So usually we expect a drug to be arranged in increasing dose. However, in this article, aripiprazole 11 comes first, followed by 2 and 3. So that is counterintuitive, and it makes the readers put in more effort to read. And in one of the plots in page number 65 in the supplement, it shows some logarithmic scales and compression of the total effect sizes. So it doesn't make sense because one of the cells become 0 and the values is expressed in logarithmic scales. So this is primarily focusing on improving the clinical utility and how the presentation could have been better. The third, I find this particular critique to be of a translation potential, because the way he looks into the article gives us some clinical insight into selection of drugs. So they focus on the literary bias, factual corrections, and the clinical nuances in ranking interpretation. So the alleged literary bias is the inclusion of lumateperone, and the factual error is the author says cariprazone had 2 drug failures, but while actually it has 3 prior anti-drug failures. So it means that they are hard to treat populations. Lumateperone's dopamine partial agonist classification has been omitted in the text. So aripiprazole's is top counter argument, which says, first, although lumateperone was first in efficacy, he finds that the difference between aripiprazole and lumateperone, the credibility interval crosses 1, which means is actually not much significant difference, is what he says. So this point I want you to look into. How do we select the agents for our patients? So lumateperone causes somnolence or sedation, and that resulted in discontinuation. It improved sleep, it improved inattention, which is not seen in cariprazine. So who is the population we need to use this on? The anxious, insomnia dominant, inattention phenotypes. It works better. And to make it more acceptable, start at low dose and improve and gradually increase it. With respect to cariprazine, the activation is more prominent, resulting in discontinuation. So it is better suited for people who have anhedonia, psychomotor retardation, and low energy phenotype. Aripiprazole, it is somewhere between this, so and cost effective to some extent. So it could be used in mixed presentation where person needs more tolerability as well as low cost. So the final says, like, this particular item level analysis on MADRS scores will help us dictate how we select the participants for our treatment. So synthesis, the first comment, it strengthens the critics and focuses more on blinding integrity. The second comment is neutral. It helps us to improve the presentation of our findings. The third comment gives a substantial insight into the clinically actionable insight. How to select a drug for what group of drug for or which phenotype of antidepressants. So this is what we get. Aripiprazole across is the best choice for evidence for tolerability and cost. Lumateperone's advantage in real world could be modest because of the heavy conflict of interest laden and worse acceptability. Yes, so the take-home message, efficacy hierarchy exists, but interpreted cautiously. Acceptability must be weighed alongside efficacy. Industry's funding and conflict of interest permeate significantly in this study. There is no head-to-head data, so ranking is probabilistic, not definitive. Real-world patients differ substantially from trial populations, so choice of drugs based on phenomenology could be a better. And the critical knowledge gap on long-term maintenance still exists, which needs further studies and approval in our day-to-day practice. So with this, I hold my presentation for a time. I have a few questions lined up. I would like the audience to go with your question answer sessions. Ma'am, over to you, ma'am.
Yes, sir. Thank you for the excellent presentation, sir. In participant pages, the session is open for questions. Please put forth your questions, doubts, or feedback. So meanwhile, I just have a doubt, sir.
Yes, ma'am.
So we use the random effects model to assess the similar methodologies in the meta-analysis. So we also say that it addresses the sample heterogeneity. So in this case, how useful it is to address the sample heterogeneity?
Random effects model, there are two. Fixed effect models says the outcome has to be similar and the scenario assessed has to be similar. The design has to be similar. So there is no difference. But what the random effects model assesses is multiple truths in a single truth. So it is a stepwise gradation that helps us address each of these truths to finally come out to one particular truth as a common effects. So in that way, it addresses, takes into account the design effect and the individual heterogeneity that happens within. So they say this probability of this happening is not possibly due to a single effect, but due to a multiplicity of factors that happens together to come out or bring out the truths. It could be a study design, it could be the population characteristics or the drug characteristics or the adverse effects characteristics. So it helps to address few more truths in a single component assay. So in that way, the random effects model works better.
Thank you, sir.
I mean, in case the audience don't have a question, I have few questions to discuss. Shall I go ahead, ma'am?
Yes, sir, please.
Yeah. So how much is the conflict of interest impacts the evidence quality? So the next is the placebo response, which is 2 times higher in cariprazole lumateperone trials compared to aripiprazole. Does this reflect real population differences, trial error effects, or enrichment strategies? With respect to clinical practice, should we prioritize efficacy or acceptability when choosing adjunctive therapy? So how do we communicate the lumateperone efficacy acceptability paradox to the patients? The next is ethics and access. With lumateperone being newly branded high-cost agent, the author who co-authored its pivotal trial also leading the network meta-analysis. How do we approach prescribing decisions? With respect to evidence gap, the paper excludes long-term data and real-world populations. What evidence would we need before routinely changing our adjunctive prescribing hierarchy? The last is research integrity. How should journal editors and institutions strengthen conflict of interest policies for systematic reviews and network meta-analysis, where selection include studies can be as influential as the analysis itself. So going to industry sponsorships, use the lens of antipsychotic trials by Spielman, which says it usually overestimates the effect size. And with 2 trials being sponsored by the author as well as the findings being disclosed by the company Intracellular Therapies itself. And does this make synthesis of evidence and simultaneous promulgations of evidence to as an advertising method? So the clinical bottom line is aripiprazole and lumateperone has a significant overlap. The difference estimates does not prove pharmacological superiority. So use hierarchies to structure patient conversations, not to algorithmically determine the prescribing. So do not, since the article says lumateperone has higher efficacy, do not blindly go for lumateperone. It does not mean it is superior to aripiprazole or other drugs. It just means it had more efficacy with comparison to placebos. So placebo response, the trial era effect, that is before 2010, the placebo response has been not well controlled. So over the years, the placebo response has been improving in antidepressant trials, and this makes it difficult for drugs to produce a significant difference. So the gap, so pre-trial era and the current era is significant. So lumateperone, on the other hand, uses enrichment strategies. As described as, there are 2 things. One is screening and a baseline entry into study. During screening, they have a score. And during baseline, they reassess. In that reassessment, they do have MADRS 24 or more, CGIs more than 4, and QIDS more than 14 at base. So this difference has to be maintained. If not, the participant who improves spontaneously are sent out of the trial or not included in the trial assess. So this makes only people who are more biologically responsive to drugs to be included. The natural responders has been taken out. This is not the case with cariprazine. So critical implications. So we cannot, the hierarchy is being mentioned as a caveat in the study, the placebo response hierarchy, but it causes a significant disadvantage to cariprazine and an advantage to lumateperone, making the prescribing hierarchy to change significantly. Should we prioritize efficacy or acceptability? On one side, lumateperone higher efficacy, on the other side, higher dropout. So what do we want? What we want is patient to be more functional, and it is a shared decision making. So rather than saying that this drug works good, say to the patient, this drug works better, but at this compared to this other drug, but at the same time, it causes more side effects or difficulties. So let the patient choose rather than us taking a call on that. So the role of the co-authorship, like, has a significant influence in this. If we look back historically, quetiapine during the 2000s, in that decade, we find a lot of literature or pharmaceutical companies pushing quetiapine as the drug for managing depression adjunctives. So the same narrative appears to reappear in this particular context. So practical solution would be to go for aripiprazole, followed by brexpiprazole or cariprazine, and third could be lumateperone for people who have metabolic risks. And what do we need before changing our prescribing hierarchy? We need head-to-head trials, which makes it gold standard and not negotiable. Long-term maintenance data, which will make it include in the European Medical Agency's registries as well. And functional and patient-reported outcomes should be given more priority over only remission or MADRS scores change. An independent pharmacoeconomic analysis has to be done, because if it involves insurance or reimbursements, then it has a significant impact. Going into what the journals and institutions should do, authorship independence requirement that has been partly included in Cochrane reviews. It says no network meta-analysis author should have received direct financial payments from any manufacturers of the drugs under the review in the last 5 years. If applied, it is unclear whether the single author would qualify or not. Prospective registrations of unpublished data requests. So instead of getting it from the sponsors as well as lead author, get it from the registered regulated mechanisms rather than unregulated copies. Mandatory sensitivity analysis by funding source. Here we found sensitivity analysis to exclude geriatric population. We also need to do a sensitivity analysis based on the funding source, whether it is industry sponsored or independent assessment. So independent assessments usually do better, just like the CATI trials or the STAR-D trials. Post-publication linkage disclosures in the form of the author should disclose any industry releases, marketing materials, or paid presentation based on the submitted work that are planned to have occurred in the last 90 days of submission. Basically, people or reviewers are kept blinded on this, so they are not sure what happens outside the article. And this could have been a major synthesis of evidences being done. And finally, all these network meta-analysis are done to set up guidelines. So the guideline requirements should require a higher conflict of interest bar and assess the NICE and Canadian drug and technologies. They have this health technology submissions to be set higher than the normal. So this has to be followed by the journals that assess this network meta-analysis. So in network meta-analysis, each of these steps are based on human judgments. So a stronger a priori structural conflict of interest protections and not post hoc disclosures will be a good safeguard. And based on, if we analyze an article like that, that would help us get into the exact nuances of prescribing and not get into the trap of marketing. Yeah. So the final take home is, though methodologically sound, clinically important, the article is compromised by its conflict of interest. So I would like to say thank you. Yes,
Thank you, sir. I'm sure all the PGs would have been benefited by this eye-opening session where we have to analyze the research papers based on the context of industry-sponsored trials and translating all the findings into clinical practice. And wise prescribing is very important. So thanks a lot, sir. Thank you.
Thank you, ma'am.
So shall we conclude the session?
Yes, ma'am. So
okay.
I thank all the audience as well as the organizers for giving me the opportunity to present on this network meta-analysis. And I thank Dr. Divya for being an excellent moderator of the sessions. Thank you, ma'am. And I thank all the audience. Thank you.
Thank you, sir.